It's a real honour. I think seeing and hearing from Paul presenting those stories from the parents, how powerful and important this topic is. And I know both me and Paul are very grateful to have this opportunity to share with you an audience of midwives and parents, because it's to get this done, it needs a team effort. And it's really valuable to be able to share our experiences and learning from doing this with maternity services. So thanks very much for this opportunity. I normally like to start my presentation with the title, An ABC of Specialist Early Newborn Care. And in this, I like to redefine the acronym ABC to Airway, Breathing, Cuddle, to highlight the importance of this contact between mother and baby, and also hopefully to portray that if you're systematic and methodical, it can be relatively simple to achieve this. So through this session, I think I'll start with just expressing some of my personal experiences and motivations for why I do this and look to practice this with my teams. We'll think about the risks related to doing the delivery room cuddle and some of the practical aspects to that. And I think hopefully round off, you'll see that by ensuring good practice in the delivery room in achieving cuddles, we actually meet high evidence-based standards that underpin our early newborn care. So my real motivation stems from hearing Charlie and Jack's story, which was the first case report of this practice in Acts Paediatrica from Paul. And ever since, I've been personally motivated to give every baby in my care a delivery room cuddle whenever it's safe to do so. And I can tell you that it feels very natural and right to provide this cuddle. And in the rare circumstances where it isn't possible, there are some, it does feel uncomfortable and not right. I think I've alluded as well that I think we all try to maintain high evidence-based standards and provide the best care to the babies we serve. And that's another motivation for me. And I've always been aware, and I think there's a good long-standing evidence base relating to kangaroo care and skin-to-skin care and neonatal neurodevelopmental outcomes. So I like to share this paper. It's back from 1991. Even then, small babies as small as 770 grams were having skin-to-skin care, not cuddles, but in the delivery room, but skin-to-skin care, and had physiological stability in their behavioural state, temperature, patterns of breathing, oxygenation, and heart rate. So feasible and possible. We also have good meta-analysis from multiple trials in all income settings showing that kangaroo care benefits babies. We see reduced neonatal sepsis, improved breastfeeding, improved pain measures, and there's the forest plot from the meta-analysis showing reduced mortality risk in babies receiving kangaroo care. And this next one is one of my favourite papers, I have to say. It's from Columbia. It's a 20-year follow-up of an RCT looking at kangaroo mother care versus traditional care. And 20 years later, the cohort that were randomised to kangaroo care had reduced hyperactivity, they had reduced school absenteeism, they had enhanced growth on their neuroimaging, and they had better jobs with higher wages. So the power of skin-to-skin and kangaroo care. More recently, we've got neurophysiological studies looking at EEG during skin-to-skin. We know that babies who have skin-to-skin with their mother on EEG show enhanced maturation of their brain patterns and enhanced sleep-wake cycling. And I'll go back there. The European standards for care of newborn have highlighted this as a very, very important topic. It's of particular importance for every very preterm infant, and they advocate that skin-to-skin contact should be initiated as early as possible as standard care. And really, you can't get any earlier than the delivery room. I'm also pleased that the Lancet highlighted this as a health research priority. So there are barriers to continuous skin-to-skin care early on, and this is a research priority from beyond 2015. More recently, we've had some direct studies of delivery room cuddles beyond just kangaroo care and the neonatal environment. There's this lovely case series looking at very preterm babies, and they concluded that those parents who experienced delivery room cuddles had strong feelings of bonding and relief at what they describe as a traumatic time. Professor Clarke also highlighted this recent study looking at surgical defects, not in extreme preterms, but we know that actually there's no adverse incidence even in babies who have open surgical defects in the delivery room, and those who had delivery room cuddles received breast milk more than those who had no cuddles. And then there are a couple of RCTs looking directly at the delivery room and skin-to-skin contact. This study showing 55 babies, the gestational age range was around 28 to 33 plus 6, so slightly more mature than the babies we're talking about, but showed really feasible to have immediate stabilization even on the maternal chest after delivery. And a similar paper here with 88 babies, mean gestation 29 weeks, but does go down as far as 25 weeks gestation. And this again randomized skin-to-skin contact with visual contact only. These were a select group of very, very well infants, not ones that needed high oxygen levels or intubated. So again, we'll advocate that it's possible even in ventilated babies to do this. But really pleasingly to see that their primary outcome of mother-child interaction at 6 months was better in those who had early skin-to-skin contact, not unsurprising. And actually the admission temperature was higher in the skin-to-skin contact group. So delivery room skin-to-skin promotes maternal-child interaction, decreases maternal depression, decreases bonding problems, and may benefit preterm development. Let's all remember those things. In terms of the feasibility in practicing the delivery room cuddle, everyone's set up in every hospital will be slightly different, and there are many contributing factors to how to achieve this safely. We'll all have slightly different equipment, we'll all have a slightly different risk population, and our delivery room setups and distances between NICUs and delivery rooms will all be very slightly different. But I honestly think that anyone who is delivering neonatal intensive care has the equipment to deliver a delivery room cuddle at the time of birth. Risks, I think we shouldn't ignore the human factor. This is a huge element. And we know that whenever we're undertaking something new or novel to us, it's important to have situational awareness, clear communication, closed loop, a nominated leader, and then have a shared and mutual understanding of the process between the team, which is why it's important that everyone in the team, the nurses, the doctors, and the midwifery team have an understanding of this process. If it goes wrong, this is an example, this is comical really, perhaps not for the footballer, but it certainly wouldn't be comical if we had poor communication, if we didn't close loop our communication and didn't have a shared goal when doing the delivery room. So it's very, very important that we acknowledge the human factors involved in this and look to minimize those. As long as we're clear of our communication and we have a shared goal, then we can start focusing on the factors which are intrinsic to the infant, which may put them at risk. So we'll all be aware that extremely preterm babies have very high surface to area volume ratios. They have an absence of insulated subcutaneous tissue. They have very wet skin and limited internal thermoregulatory means, which of course means they're all at risk of hypothermia. There'll be surfactant deficiency and premature lung architecture, which means they'll be at risk of respiratory instability. And of course, there's limited energy stores, particularly if we get them cold or make them work hard with their breathing, and that may place them at risk of hypoglycemia. But honestly, all these things can be controlled. We control them in the neonatal unit. We can control them when you've got a whole neonatal team next to this baby and mother in the delivery room. I often think there's at no point in this baby's lifetime when they're going to have such a strong team supporting them in terms of the seniority and the number of staff that are going to be there in that delivery room. Of course, preparation and planning is vital. It's the same when you're preparing for any extremely preterm baby, regardless if you're planning to introduce this practice of cuddling in the delivery room. But we need to ensure we've got perinatal optimization, of course, delivery in the appropriate center, steroids, magnesium. We need to have a clear plan and communication. This is again why it's vital to have the maternity team involved, because we need to be clear about if there are any complications or contraindications that may preclude a cuddle. And of course, it's vitally important in terms of minimizing the risk of hypothermia that we control the room temperature, minimize drafts, and appropriately counsel parents. So we don't want to make false promises if we're going to say, oh, we do delivery cuddles here, and then suddenly we don't offer that to the parents. That would be very bad. But equally, we should strive to where we can, and we should just have discussed this is a potential, particularly if we can stabilize the baby in a way that makes it safe. Stabilization, The routines, we need to ensure that we've done optimal cord clamping. After that, we need to have definitive respiratory support, whether that's CPAP, intubation, high flow, whether or not the baby needs surfactant. And once the monitoring and stabilization is achieved, that's the point at which we look to progress to the delivery room cuddle. And this is all in mine and Paul's papers, along with two of the parent authors, Emma and Sheila. We have a little assessment criteria to know that the baby's suitable for cuddling. And this is that we can achieve adequate saturations with the potential to increase our ventilation if needed. We have a stable heart rate. Vitally important that we have an adequate temperature before starting, because if we start a cuddle with a baby cold, then they will get cold. Whereas if we have a good normothermia, then we can maintain that during the cuddle. As I've mentioned, we want a definitive means of offering respiratory support, whatever the baby needs. If they're intubated, I would advocate that we should have some form of capnography, so that's carbon dioxide monitoring to ensure the tube's in place. And we need to think about some of the cautions and contraindications that Professor Clarke explored earlier that may just mean in this situation we can't offer the cuddle, though they are rare. To highlight again, a stabilised infant, a stable airway, definitive respiratory support, optimised thermoregulation, no contraindication. The surrounding team, neonatal team, the midwives, the anaesthetists, the obstetricians, all updated. And it's very important that the team around the neonatal nurse and doctor are able to facilitate this. So the logistics are ensuring the mother is ready, ensuring there's a clear path between the baby and the mother to transport the baby there. And making sure that the mother is of course medically fit and not needing emergency care herself. This is very important. Reassuring the parents, unless they're appropriately counselled as to how the cuddle is going to be facilitated, this could be very, very scary for them indeed. So I like to ensure that the parents are aware we're going to be there with them. The baby is stable for the cuddle. We've assessed that. The baby continues to receive the optimum care. They're being continuously monitored and safe. They're comfortable, and of course encourage photos and videos of this precious moment, because this is something that the parents will often look back and cherish. And then we get to cuddle time. And really this is just ticking the boxes, crossing the T's, making sure that we've got adequate paramedical gases, we've got our continuous monitoring. As part of this that isn't routinely practiced through the UK, I would advocate using continuous temperature monitoring of the babies to ensure that they don't become hypothermic. And if we can achieve all this, then the steps taken to ensure the safety of this baby during the cuddle, they represent ongoing intensive care. They're nothing new, but they do represent good practice. Equipment will vary between trust and hospital, but you're going to need something to stabilize the baby on, a resuscitaire. You're going to need a plastic bag or suit. You may need a transwarmer. You're going to need a hat cover or a head cover, maybe a hat, maybe a hoodie. For breathing, you may need to tube the baby, but you're going to need a means of either ventilating that baby or offering CPAP during the cuddle. And for monitoring, you're going to need a means of monitoring their heart rates and SATs, which everyone's going to have in the delivery room. I would advocate for an ability to monitor the temperature. I do that by taking the block off my monitor in the ward and take it down to the delivery room. But actually, most resuscitaires also have a temperature monitor. And then, of course, I've mentioned there that continuous carbon dioxide monitoring is important to check that ventilation is ongoing and the endotracheal tube is actually in the trachea. And I've got a picture there you can see just of the resuscitaire showing that most of them will have a skin temp probe, and it's just about finding the lead, to be honest. So there are different ways of transporting baby to the mother. If you've got a good transport incubator, then you may like to transfer the baby into that incubator and then move the incubator alongside the mother, and then offer your invasive ventilation or non-invasive ventilation using that the transport incubator's ventilator. I like to do that because my model will allow me to give volume targeted, but that's not essential. And you can then have your monitoring system next to the baby there as well. The other possibility is moving the resuscitaire next to the baby as shown here, and you may like just to use the Neopuff to offer your ventilation via an ETT tube. Or it can be possible to use a mask over the nose and mouth of the baby and offer CPAP in that regard, although this does require a skilled operator. This is all available, as I said, in our open access paper in ACTA. During the cuddle, there are other things that can be done. As I said, the infant's care isn't put on hold. You can think ahead. You can notify NICU that the baby's ready. We're doing the cuddle. We'll be coming to you shortly. You can prescribe infusions, have antibiotics, caffeine, vitamin K ready. And of course, NICU team can have their ventilation ready, their access trolley ready, and have all their infusions and syringe drivers ready. So if you work as a team and work in parallel rather than in serial, then you can achieve a lot. And certainly this doesn't take up any time. And as we've seen from our case series, there was no difference in time to admission between babies who had a cuddle and didn't. It's a very special moment. Here again is Jack receiving his delivery room cuddle. You can see that he's got his ET and is receiving his ventilation via a neopuff. And this is an example of, I think this is a 33-weeker receiving delivery room cuddle CPAP with use of the face mask there. So really just to summarize, plan and prepare. Ensure you've got firm regulation, respiratory stability, and a definitive airway, whether that's the baby's own airway or an intratracheal tube. Prepare the team, prepare the parents, have monitoring throughout, and encourage photographs and videos. So ongoing attention to firm regulation, ongoing provision of respiratory support, effective monitoring. High-risk human factors can be controlled with good communication, and the steps taken to achieve this cuddle are good practice and enhance the baby's care. Finally, hopefully many of you will be looking to encourage us on your unit if you're not doing it already. I think it's important to have a good plan in place before you just offer this to any extreme preterm baby, particularly with those human factors. There are risks that need controlling. You can control them with a guideline, training, simulation. You can start off with bigger babies and then go to smaller ones. Then you're well rehearsed when the tiniest do come. You're going to need MTT involvement. So you, the midwifery team, the obstetricians, anaesthetists, and of course the neonatal team and local champions are vital to disseminate knowledge, troubleshoot, and stoke enthusiasm. And finally, as we've shown, I think audit and governance, as with any new practice, is very important. I'll end here with our paper, which you're welcome to have a look at. It's open access. There's lots of supplementary resources. Those very powerful videos that Professor Clarke showed are also available online for you to be able to watch and share as well. And again, thank you very much for this opportunity. And I know myself and Professor Clarke are very happy to answer any ongoing questions relating to this.
Welcome to everybody who's come this evening. I think we've got an interesting evening. I hope you're going to enjoy it.
I remember another patient who we both looked after, who, you know, was in a relationship with a chap, getting serious, thinking about starting a family. And I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was trait. This was one of our patients who had sickle cell disease, and she dumped him in the room.
Yes, she did.
She dumped him in the room in front of
us.
I remember.
And I said, Mummy, I'd never let you get a vaccine that is not safe. So I'll be the first one there, and then once I've had it, you can have it. And I remember this text message coming back to me while I was at work, where you'll be the first to die. For every touch point, be talking to women about the importance about having the vaccine. And if you don't have information, say that to somebody. I don't have the information. Can I pass it on to the person that can?
Some women are saying that they're actually having a really positive breastfeeding experience because their situation of having to stay at home and not having lots of visitors around and not feeling they have to rush about everywhere means they've actually got the excuse almost to sit on the sofa and just breastfeed their baby.
So Black and brown women and birthing people are not treated with equity, leading to unacceptable levels of morbidity and mortality. They then become marginalised communities that become mistrusting of maternity services, and they might be reluctant to engage because their initial experience has been negative. We then label them as difficult and unwilling to engage, and the cycle of substandard care continues.
It's really difficult to describe really what makes continuity happen, but there is some real magic in the depth of relationship that you have with a woman and her family, and it's really beyond articulation. We know it works. It definitely works for our women and our families, and if you always put them in the very centre of what you do and how you work, that is when the magic happens.